Okay, welcome everybody. It's a pleasure as always to welcome you to this seminar of the Health and the Public Interest Program at Georgetown University. I'm going to start by telling you a little bit about the program and then we'll move on to introduction of the speaker. So the Health and the Public Interest Program is now in its fourth year at Georgetown University. It's a unique program in that it looks at public health, healthcare, personal health from the standpoint of non-medical factors. That is things like psychology, ethnicity, culture, etc., marketing influences. And as such, then it's somewhat like a public health program, but really emphasizes these other aspects. And in particular, it looks at advocacy and activism and how through these modalities health can be furthered, or how health can be affected, let me put it that way, which is right in line with today's seminar by Dr. Vincent Iacopino. I want to say a word, not of introduction, but of explanation, that it's a special treat for me to have Dr. Iacopino give this seminar today, because he started at Georgetown the same year I did, somewhere in the mid-Jurassic period, I believe, in 1979, when I was starting the PhD program. And you'll probably hear from Dr. Iacopino about his medical and graduate training. I hadn't really kept up with him very much, but or at all really, and didn't know him that well back in those days. But he did stop by once or twice and tell the people in the department what he was doing. And so something happened about a year ago, I guess, that just triggered my memory and made me wonder, okay, what has Dr. Iacopino been doing since one of those meetings, which took place a couple decades ago? And I looked it up and found a fascinating history of involvement in health justice and its effects on health, which fits in beautifully with this program. And so I reached out to him, and voila, here we are. And you get a more formal introduction now in a moment from Ryan. So he's, excuse me, I'm thinking and talking at the same time, which at my age gets a little difficult sometimes. But I wanted to just tell you how we're going to conduct this seminar. Dr. Iacopino has about 40 minutes of material. He's going to give that material, and I'm sure you'll be fascinated by it. We're going to ask you to either put questions in chat or preferably hold them and give them verbally at the end of that 40 minutes. We'll start with raising of hands by health and the public interest, happy students, and then move to the more general audience. And as always, the outside audience is greatly appreciated, and we'll save time for your questions. And please spread the word about this program and this wonderful free seminar series. And I'm sure you'll be pleased with this talk and want to come back for more. So Ryan, the floor is yours.
So hello, everybody. It's my pleasure in introducing our speaker today, Dr. Iacopino. Dr. Iacopino has played a crucial role in conceptualizing the relationship between health and human rights, and has been an author on over 100 publications. He is the former medical director of the Physicians for Human Rights and is currently serving as adjunct professor of medicine at the University of Minnesota Medical School and as a senior research fellow at the Human Rights Center at the University of California, Berkeley. He has been the recipient of the Center for Victims of Torture's Eclipse Award for extraordinary service on behalf of torture survivors, and the Distinguished Alumni Award from the Department of Medicine at the University of Minnesota. So rather than trying to summarize the interesting journey that Dr. Iacopino has had to reach this point, we discussed that we were going to keep this introduction brief and let Dr. Iacopino take it from here. So thank you.
Well, thanks, Ryan. I appreciate the intro, and welcome everyone. As Ryan said, I'm talking about health and human rights today, and my hope is to provide you with a critical perspective on health and human rights, the linkages and so forth, that will help you and inform you, your future practices in health and the advocacy work that Adam talked about. As Ryan said, I'm going to refer to my own personal experiences as a vehicle to illustrate the connections between health and human rights, starting with the old days at Georgetown, when Adam was chasing me down for my platelets. It seemed that he had a needle in his back pocket. Every time we got together, it was for a couple of ounces of blood. So about 40 years ago, I was a student just like you at Georgetown. First I was in the master's program in physiology, and then as a PhD student and a medical student. You could say that I was on a well-worn path of academic research, studying the cardiovascular actions of the mediators of anaphylaxis and learning to diagnose and treat illnesses. During the last year of medical school in 1985, I spent 2 months working in a refugee camp, a Cambodian refugee camp, and another year during my residency in internal medicine at the University of Minnesota. The experience of providing medical care in an active war zone, in the aftermath of genocide, and in the context of a chronic humanitarian disaster, it really changed my life and career trajectory. As you may know, Cambodia was really devastated by the Vietnam War, 400,000 casualties from secret US bombings, which destabilized the country and enabled the Khmer Rouge to assume power. Between 1 and 2 million Cambodians died from starvation and disease and executions from the Khmer Rouge. And then in 1979, hundreds of thousands fled to the Thai border, where Vietnamese forces, when the Vietnamese forces assumed control of the country. The Thai government had these horrendous policies of exposing people to war, and they kept camp conditions really awful. We were providing medical care under these circumstances. And I realized that, the medical care had very little to do with the suffering that people were experiencing, the ongoing war, attacks by the Thai security forces, effectively being imprisoned in the camp, no electricity, clean water, sanitation, and really no hope of resettlement to a third country. My knowledge and skills were basically irrelevant to addressing the social causes of suffering that I was witnessing. And my location downstream and at the bedside really limited my ability to take effective action. So maybe there's no better example of this understanding than the medical treatment of landmine injuries. Is it enough to simply amputate a limb and rehab with a prosthesis, or do we have a responsibility to address the causes of these kinds of injuries? And if so, how do we do that? I want to say something about an experience that I had at the end of my time at Georgetown. I had the great pleasure of hearing Jack Geiger speak on behalf of Physicians for Social Responsibility at that time. He was talking about the health consequences of nuclear war. Jack was a giant in public health and a leader in social medicine. He started the community health center movement in the US, and that really inspired a national network of more than 1,000 clinics that currently serve about 28 million low-income patients. He was also a founding member of Physicians for Social Responsibility and Physicians for Human Rights, 2 Nobel Peace Prize winning organizations. Jack's message that day at Georgetown was simple and very instructive to me. He said, the only rational medical response to this prospect of nuclear war is prevention. And little did I know at that time that Jack would become my mentor at PHR and a lifelong friend. After completing my residency and a chief residency year in internal medicine, I worked in the highlands of Papua New Guinea, a place where evil spirits were considered to be the primary cause of human suffering. For example, this young man presented to our hospital after a traditional healer performed a bush thoracotomy, instilling unsterile water into the chest cavity and observing pus as a confirmation as an evil spell that was cast on him by another person. So for me, the dramatic health practices like this underscore the relationship between epistemology and health practice. That is, our understandings of the causes of human suffering manifest in different health practices. So when evil spirits are thought to be the cause of people's suffering, health practice manifests as rituals and exorcism. If the cause of suffering is simply disease and injury, then health practice consists primarily of curative medicine and hopefully some prevention. The notion of the biopsychosocial model expanded this to include psychological and social domains, relationships. And more recently, the concept of social determinants of health has helped to health practitioners to understand that the effects of social conditions on health outcomes are very significant, albeit measured in terms of morbidity and mortality. Perhaps the most expansive definition or understanding of health comes from the World Health Organization that defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This definition requires health practitioners not only to address social causes of morbidity and mortality, but human rights as well, I would argue. So after working in Papua New Guinea, I started a postdoctoral fellowship at the Robert Wood Johnson Clinical Scholars Program at Stanford. And in conducting a 2-year qualitative research project on understanding human suffering, I approached a treatment center for survivors of torture in San Francisco, one of just 3 at the time in the US, seeking a collaboration. But instead, they immediately made me their medical director. This is where my career kind of goes sideways towards human rights. So at Survivors International, we not only provided medical and psychological care, but also social and economic support in the form of job placement and food assistance. We also conducted asylum evaluations to assess physical and psychological evidence of allegations of torture. And that had a profound effect on the adjudicators' decisions and providing relief for people who suffered extraordinary trauma. It was very satisfying and immediately satisfying experience to testify in court. So I'm not sure exactly why in 1992 I went to Boston to attend a PHR conference on medicine and human rights, but I did. And given my newly acquired skill of documenting clinical evidence of torture, and there were only 3 of us in the country at the time who were doing that, and my experience of working in Thailand, PHR immediately asked me to participate in several human rights investigations. First, documenting excessive use of force and disappearances of pro-democracy demonstrators in Thailand. Then investigating and documenting torture, political killings, and disappearances in Punjab, India, as well as torture, political killings, disappearances, rape, attacks on health professionals and health facilities in Kashmir. I mean, at that time, Kashmir was the most dangerous place on earth, in my opinion. So through the work of Survivors International and Physicians for Human Rights, PHR, I clearly and painfully understood that human rights violations had extraordinary physical, mental, and social health consequences. And I began to feel that I was working both downstream, treating survivors and documenting human rights violations, and upstream, finally, preventing future abuses through documentation. Really, the full range of health and human rights linkages that were not evident to me until I began working with the Human Rights Center at the University of California, Berkeley. In 1993, I began teaching a health and human rights class, so I really had to learn about human rights at that time. And fortunately, at that time, I also had the great pleasure of meeting Dr. Jonathan Mann at the UN World Conference on Human Rights in Vienna. He was the head of UNAIDS at the time, and he described 3 critical linkages between health and human rights. First, that human rights violations have health consequences. This is my experience and how I came to health and human rights. For example, torture and war, slavery, etc. It's pretty obvious what the physical and psychological health consequences are. But also unrealized social and economic rights, such as the right to work and education. We know that from our social determinants of health understanding. Second linkage, that health policies can be discriminatory and have health consequences, especially at that time HIV/AIDS policies, and reproductive rights. The third linkage, and most importantly, is that human rights are intrinsic to health, meaning that human rights are essential conditions for health as defined by the WHO. So the intrinsic perspective, it focuses on the inherent dignity and worth of individuals as primary outcomes rather than morbidity and mortality. So for example, think about torture. Torture is not, from the intrinsic perspective, torture is not a health concern solely on the basis of physical and psychological health consequences, but because it represents an assault on human dignity and the worth of humanity as a whole. Think about education. The reason why we educate kids is not because of its association with improved health status, which we know is very strong, but because education is a condition for human well-being. These are just a couple of examples. We can talk about more. Okay, so we're talking about human rights now. So what are they, right? I imagine most of you haven't really studied human rights in school or in graduate school. So you can trace human rights, the idea of rights, back into history. We're not going to talk about that, but really they were first articulated after World War II. They were rhetorical statements, basically, of moral identity in the aftermath of the horrors of World War II and the Holocaust. And they weren't philosophical principles, they were social claims that sought to promote the dignity of all people. And they constituted legal obligations of states, the duty bearers of rights, to respect, protect, and fulfill human rights. And they're also entitlements of people, the rights holders. These are individual claims of rights holders. Rights are considered to be universal, meaning they apply to everyone. Interdependent, meaning any one right depends on the fulfillment of others. And indivisible, they come as a package. You can't just simply endorse some and not others. And as I said, I and others would argue that human rights are the essential conditions for human health and well-being. Okay, so the first human rights documents were the Universal Declaration of Human Rights, established in 1948 after the war, soon after. And then two subsequent legally binding covenants that came into force in 1976, not that long ago. The International Covenant on Civil and Political Rights and the International Covenant on Economic, Social, and Cultural Rights, known together as the International Bill of Rights. Those were the first documents. Some of the civil and political rights examples are freedoms from arbitrary deprivation of life, torture and ill treatment, slavery, rights to non-discrimination, liberty and security of person, to due process and protection against arbitrary arrest, political participation and voting in periodic elections, and to marry and found a family, which for me didn't seem so relevant at the time, but later it did when I learned that that right was in response to the practice of eugenics in the United States and later in Nazi Germany, when people were euthanized and later gassed. And also freedoms of speech, thought, conscience, religion, of assembly and association. Some of the economic, social, and cultural rights are rights to work under favorable conditions, to form trade unions, to Social Security, to an adequate standard of living, and the highest attainable standard of health. There's a lot written about that. To education, to take part in cultural life, and to enjoy the benefits of scientific progress. I'm just giving you an idea of what some of the rights, the articulated rights are in the International Bill of Rights. Since 1976, there have been dozens of international treaties and conventions on very specific human rights issues like torture, slavery, the rights of children and women, stateless persons, genocide, etc., all of which apply during times of peace. Some are non-derogable rights and apply during times of war as well, but mostly during times of peace. There are other categories of law, the laws of war, so-called international humanitarian law and international refugee law. I just want you to know that there are these big bodies of human rights law that are somewhat distinct and worth studying. My advance, here we go. So I want to talk about the limitations of human rights discourse. As strong as it is, there are very significant limitations. enforcement and state accountability are limited by provisions of domestic jurisdiction, sovereignty in the UN Charter. And enforcement by UN bodies is really limited to just reporting and monitoring mechanisms. There are stronger accountability mechanisms in the international and human rights courts, however. Also, non-state actors such as individuals, these billionaires that we have these days, and transnational corporations, they don't have human rights duties per se, directly, and despite their immense power and the control that they have over states today. Human rights are often eclipsed by other national interests, political, economic, and national security interests. And rights concerns in governance is often limited by the lack of public constituencies for rights, because there's very little human rights education, like in this country particularly, but also in many others. So now I'd like to transition and talk about my work with PHR. Now that we know a little bit about human rights, here are some examples of how health professionals can use their knowledge and skills to prevent the health consequences of human rights violations. PHR is a non-governmental organization founded in 1985. We conduct research and investigations, document human rights abuses, and we publish our findings and advocate for accountability, the prosecution of violators, and policy reforms for prevention. We also provide court admissible evidence and serve as medical experts in legal cases. Some of our methods: forensic investigation, clinical assessments of physical and psychological evidence, analysis of physical evidence like x-rays, soil samples, DNA, case review of medical records, witness interviews, population-based surveys using epidemiologic methods. And typically we're triangulating with multiple methods. We use qualitative methods to provide insight into individual abuses, and quantitative methods to document the prevalence and patterns of human rights practices. I should say human rights abuses. Okay, so PHR pioneered the utilization of forensic anthropologists, archaeologists, and pathologists to collect physical evidence of war crimes, usually at the request of governments, as shown here in Guatemala, or for international criminal tribunals, as was the case in documenting war crimes against crimes against humanity and genocide in Bosnia and Rwanda, which resulted in the prosecution and conviction of responsible government officials. A very satisfying turn of events for us. PHR has documented critical evidence of the use of sarin nerve gas by Saddam Hussein in Kurdistan in 1988, and by Bashir al-Assad in Syria in 2013. I apologize for the graphic nature of these slides. Unfortunately, it's unavoidable in trying to gain an understanding of human rights abuses. I'll just say something on an aside. This kind of work really requires attention to professional wellness and to prevent burnout and vicarious trauma and so forth. It's a very big subject for us and people who work in humanitarian assistance, and it's something, if you do this kind of work, you have to attend to those concerns. So PHR has applied epidemiological methods to document the medical consequences of landmines in Cambodia, and in 1992, that was in 1992, and we estimated that 1 in every 236 Cambodians was an amputee from a landmine. Quick story: one day, a small group of human rights activists got together. They dared to think of a world without landmines, and after many years and a lot of hard work, several hundred organizations came together and formed the international campaign to ban landmines. PHR was among the 6 founding members and was a co-recipient of the 1997 Nobel Peace Prize. Today, there's an international treaty that bans the production, sale, and distribution of landmines that 167 countries have signed, not the US. So we've been documenting physical and psychological evidence of torture and ill treatment for 35 years. A lot of that work has been international, but we've also extensively documented US torture practices in the government's war on terror. We also have a network of more than 400 clinicians who conduct asylum evaluations. of people who are alleging persecution. And I believe that the Georgetown medical students who are participating in this call are part of that network. We've also led the establishment of the UN norms on the effective investigation and documentation of torture and ill treatment, known as the Istanbul Protocol. These norms establish guidance for states to fulfill their treaty obligations, to investigate, prosecute, and punish acts of torture, and to empower civil society to hold states accountable. Before that, there was no such thing. Actually, it was my honor to lead the development of the Istanbul Protocol, and it was basically emerged from our work in documenting torture in Turkey, recognizing that the government refused to effectively document while medical experts in civil society were excluded from documenting. So the IP really helped turn the tables to compel states to use international standards and to validate the civil society clinicians who were acting, providing accurate testimony. Let's see. All right, so I double advanced here, sorry. So as I mentioned, PHR documented the widespread and systematic use of torture by the US government of national security detainees and the critical role that medical personnel played in facilitating torture practices. I'd love to spend an hour just telling you about that horrendous state of affairs and the sort of the worst scandal of medical ethics in US history. And we've also provided expert testimony in a number of Guantanamo cases, regional human rights courts cases, federal habeas cases, military commission cases, and currently before the Supreme Court. We've documented the horrendous conditions and inhumane treatment practices in prisons, and that work has resulted really in the closing of prisons and the suspension of abusive practices. More recently, we've documented the conditions in detention facilities on the US-Mexico border and the practice of family separation as a form of torture. We've documented conditions for refugees and successfully advocated for the deployment of much needed humanitarian assistance. And we've pioneered the use of epidemiological methods in documenting human rights violations. For example, war crimes in Kosovo and Chechnya, women's human rights violations in Afghanistan and Iraq, HIV/AIDS discrimination in Nigerian health sector, war-related sexual violence in Sierra Leone, and genocide in Darfur, just to name a few of them. I'm going to go through a few examples of the population-based assessments. Here in Kosovo, where our work revealed that 1 in 3 refugee households experience 1 or more serious human rights violations, such as beatings, killings, torture, and also that the Serb forces were responsible for large population displacements, not the militants who were fighting the government or NATO bombings, as the government had claimed. In Afghanistan, our population-based research documented the extent of the Taliban's restrictions on women's education and work opportunities, as well as very high rates of depression and women's strong support for women's rights. In Sierra Leone, PHR's work, population-based work, documented that 94% of households reported 1 or more abuses, such as abduction, beatings, killings, torture, and forced labor, all war crimes. And while 9% of all women reported experiencing war-related sexual assault, if you ask them, of the women who actually had contact with government forces, 53% reported being raped. So you have to be clever in the way that you survey people. You can't have an instance of sexual assault without any contact with a perpetrator. The documentation that we did was transmitted to the UN Special Court and the Truth Commission, and it really helped to establish the context for individual claims of war crimes. In Darfur, through eyewitness testimony of Darfurian refugees in Chad and satellite imagery, PHR compiled a composite picture of massive destruction in Darfur as evidence of an organized attempt to destroy non-Arab groups. It was the first time ever that the destruction of livelihoods condition in the Genocide Convention was used by the UN to establish the crime of genocide. It was largely due to PHR's work. So in our extensive research on HIV/AIDS and human rights, we found that food insufficiency was associated with risky sex practices among women, illustrating the necessity of addressing basic human needs, in this case, food, to prevent death and disability from HIV/AIDS. This is a study that received a number of publication awards. We've documented attacks on health professionals and facilities, so-called violations of medical neutrality in many countries over many years. For the past 10 years, PHR has chronicled the deliberate attacks by the Syrian government on courageous health workers. They risk their lives daily to help the sick and wounded, and attacks on facilities that they work in. These days, they're mostly underground because most of the ones above ground have been destroyed. We've documented the excessive use of force by law enforcement in many countries, usually in crowd control settings. For example, in Turkey during the Gezi Park protests shown here, but also recently in the US in Black Lives Matters protests. Again, these are just examples of the kind of work that we do. In 2004, we conducted psychological evaluations of juveniles on death row in Texas and found a high prevalence of undiagnosed psychological disorders, depression, suicide, and a history of child abuse. These findings, in the context of incomplete frontal lobe brain development in juveniles that we know about, right, were instrumental in a subsequent US Supreme Court decision that banned capital punishment below the age of 18. So there was a very direct link between our work and that decision. So unfortunately, many of our colleagues are in prison, sometimes killed for their human rights work. And we have and we will continue to advocate on their behalf. Sorry, it's advancing. Here we go. And we've worked with colleagues around the world to establish rights norms. For example, as I mentioned, with the Istanbul Protocol on the effective investigation and documentation of torture and ill treatment, also on the effective death investigations and documentation of sexual violence, and recently on non-coercive interviews of detainees to prevent torture in custody. These norms have really helped to hold states accountable and to empower civil society actors, are a very important strategy in working upstream. We've also trained a global network of human rights defenders, which has a multiplier effect on the international human rights documentation efforts. Again, it's a different strategy than being downstream and documenting individual abuses. And in addition to the capacity building work, we've undertaken large-scale, multi-year efforts to implement effective investigation and documentation practices of torture and ill treatment. I worked for 8 years in Mexico and 9 in several Central Asian countries. The implementation projects envision a sea change across legal, judicial, health, and law enforcement sectors. And really, they involve a couple of things: awareness raising about standards, et cetera, human rights standards, capacity building of target groups, legal, judicial, and administrative reforms, as well as active engagement with civil society. So these are enormous projects that really try to change the conditions to enable effective investigation practices. PHR has conducted similar large-scale multi-sectoral implementation efforts on the effective documentation of sexual violence in conflict in 5 African countries. And the work has included forensic training for relevant target groups, networking and collaboration between legal, health, and law enforcement sectors, and litigation and advocacy for legal and policy reforms. All right, so we know that human rights violations have health consequences. Do health professionals, do you actually have a duty to protect and promote human rights? Let's examine some of the principles of ethics, medical ethics in this case. What are they? I imagine some of you know these, but if you don't, non-maleficence, which is do no harm, beneficence, do good for your patients, confidentiality, competence, autonomy, people get to decide, make their own decisions, informed consent, justice, that's usually all about resource allocation, and fidelity. But really, the codes, the principles of medical ethics are born out of abuses by health professionals. They're codes of conduct that regulate clinical encounters of individual patients, right? They don't provide a definition of health at all. And they don't establish a duty to protect and promote human rights. The American Public Health Association's ethical principles are a little bit better, but my critique is that these principles are aimed primarily at addressing the fundamental causes of disease rather than the conditions that affect health, and respecting rights in the course of achieving community health. It's not a matter of addressing rights as a primary objective. Okay, so we've talked about the health consequences of civil and political rights, torture, killing, et cetera. What about the health consequences of social and economic rights? This is not PHR's primary focus, but I want to talk about some of the significant advances in addressing social causes of human suffering. And some examples, the discourse on global health, although that's often medicalized, on social determinants of health and social justice. As you may know, between 2000 and 2015, there were Millennium Development Goals that focused on poverty, hunger, education, gender equity, child mortality, maternal mortality, HIV/AIDS, and the environment, which had only limited success. I think a lot of it had to do with a narrow vision of these specific concerns. In 2015, the MDGs were expanded to the 17 Sustainable Development Goals. And as you can see here, they greatly expanded the concerns, including water, sanitation, energy work, inequality, safe communities, sustainable ecosystems and development, consumption, also climate change, peace, and access to justice. Wonderful, right? We'll see where that goes. It's by 2030 when they're supposed to be achieved. During the past 20 years, there have been global partnerships to address communicable diseases, very successful, many of them, and initiatives by health organizations and professional associations to address the effects of trade policies on health and accountability of transnational corporations. There was something very significant in 2000, the Jubilee 2000 effort to address extreme poverty, where $100 billion in debt owned by 35 countries was canceled, following the petition that was signed by 21 million people in 62 countries. A really extraordinary thing to suddenly reduce that burden and its effects on poverty. And just recently, for those who follow the news, I think it was just Friday when the UN recognized the right to a healthy environment. I mean, it sounds like a small thing, but it took 30 years for that to happen, and the effort of many people from business, civil society, et cetera. The WHO announced a malaria vaccine for kids with a 70% effectiveness, and 136 countries established a minimum global corporate tax of 15% to address corporate tax evasion, which is in the billions every year that people don't get to see in their social expenditures. So despite improvements in global health during the past 20 years, such as reductions in poverty, extreme poverty, increased life expectancy, declines in under 5 mortality and maternal mortality, the prevalence of some communicable diseases, including HIV/AIDS, we still face extraordinary global challenges. My career is ending and yours is perhaps just beginning. And these are some of the challenges that you face, and I'm sure you're acutely aware of them. As you know, global warming is now an existential crisis for humanity and the planet. Do you have something to say about that? Is it a responsibility that health professionals should take on? Yes, of course. Global inequality. So it's been increasing over the years, and the wealth of billionaires and transnational corporations is basically out of control. Nearly half of the world's population is living on less than $5.50 a day. That's like $2,000 a year. The world's richest 1% have more than twice as much of wealth as 6.9 billion people out of the 7.7 or however many we are now. In 2018, 69 of the top economic entities, they were corporations, not states. And in 2021, corporate tax evasion cost governments up to about $430 billion annually in lost tax revenues. In recent years, the power of states and representative governance has been at the mercy of billionaires and transnational corporations. You know, in this country about Citizens United and the effects it's had of control of billionaires and TNCs on state policies. Military expenditures far exceed social expenditures. You know, we reach for war oftentimes before any other solution to problems. And we're witnessing, as you know, and depressingly, we're witnessing the rise of authoritarianism around the world and corruption and discrimination in all its forms, as well as unprecedented attacks on truth and science and extreme political polarization and hate. This is the world that we're living in now. So recognizing these enormous challenges and reflecting on my 40 years of health and human rights experiences, I have a little bit of advice for you. Understand and address the causes of human suffering. Use your knowledge and skills to promote health and human rights. Understand the big picture, who's benefiting and who's losing from your health practices. Don't be a bystander to inhumanity. Your location matters. Work upstream and downstream, or preferably both. I mean, it's perfectly fine to be, you know, doing healthcare, let's say as a surgeon, taking out people's lungs for lung cancer, but don't you have a responsibility to do something about the cause of lung cancer, tobacco use, and the many problems that cause the end effect of what you see? Think big. Dare to think big and be humble and work in partnerships. I've never really done anything significant by myself. You have power in partnerships. Take care of yourself along the way and others. And lastly, understand that bending the arc of the moral universe towards justice, as Martin Luther King said, it requires power. And realizing that human rights in small places. I'll explain what I mean by that. So King put it this way, power properly understood is the ability to achieve purpose. It is the strength required to bring about social, political, and economic changes. In this sense, power is not only desirable, but necessary in order to implement the demands of love and justice. And Eleanor Roosevelt, who was the driving force behind the Universal Declaration of Human Rights, she said on the 10th anniversary of the Universal Declaration of Human Rights, where, after all, do human rights begin? In small places close to home. So close and so small that they cannot be seen on any maps of the world. Unless these rights have meaning there, they have little meaning anywhere. Meaning that respect for human dignity is more than a matter of holding states accountable. It is a way of being in the world. Thank you very much, and I look forward to our discussion.